Okay, so I think we're ready to start. So hello everyone, and welcome to our educational webinar on the utility and benefits of X-ray imaging in the growth room. My name is Richard Welton, and I'm the Director of Marketing at KUBTEC. I'm joining you from our lovely KUBTEC headquarters in Stratford, Connecticut. We also have online our speaker, Jay Innerhofer. He's joining us from New Mexico, so welcome, Jay. Jay is a pathologist assistant. He works for Pathology Associates of Albuquerque. He is a clinical lecturer at the Department of Pathology at the University of New Mexico, and he is also a faculty preceptor at Rosalind Franklin University Presbyterian Hospital. Now, I noticed that we have a wide audience that is registered for this webinar, coming from all around the world. I can see great representation from the US and Canada, certainly, but also good contingents from South America, Europe, Asia, Africa, and Australasia as well. So welcome to all of you. Thank you for taking the time to be with us. Now, Jay's got a really great presentation lined up for us today. He'll certainly be sharing an overview of X-ray imaging in the growth room and some of the key features of his KUBTEC system. He's also got a number of very interesting cases which will really showcase the versatility of X-ray imaging, and he'll also explain how he charges for X-rays and how to make a case for purchasing a system. And he has some example data from his own facility. To ensure that we're going to stay on schedule, we've actually gone ahead and pre-recorded the main presentation. We'll play that for you in a moment. It will last about 30 minutes or so, and at the end, Jay will be here for a live Q&A session. You can place your questions at any time during the presentation into the questions panel, which you should be able to see on the right-hand side of your screens. And now Jay and I will turn off our cameras and microphones, and I'll ask my team to begin playing the webinar recording. Thank you.
Thank you.
Hi, good evening, good afternoon. This is Jason Innerhofer. I'm a pathologist assistant here in Albuquerque, New Mexico. I've been a PA for 20 years now, and I want to thank KUBTEC for allowing me to present this PowerPoint presentation, this webinar to you. And I want to thank you up front for watching this video. You'll see on the screen, the title screen here, there's a PowerPoint QR code. You guys can certainly scan that, download it, and follow along on the utility and benefits of the KUBTEC Expert AD. A little preface, as a PA or even a pathologist, our main goal daily is to be as accurate and to be as efficient as possible. And you'll see by the end of the presentation that the KUBTEC helps us be more accurate and more efficient while utilizing, our experience as a pathology assistant or pathologist's assistant, and also based off the gross appearance and in breast pathology, the radiographic image. Here is the learning objectives and kind of the format of this presentation. A little bit of an introduction, features overview, and where it excels is basically all in one. How it works, pathology and surgeon collaboration, versatility, quality and safety, time and money savings, funding, and then the final cut at the end. And then questions also. In the bottom left corner is a radiographic image of a mastectomy, and I've copied and pasted the variety of markers out there in the names of those markers. These markers have been utilized in soft tissue tumors and also predominantly breast cases since 1995. And these markers are what we look for and identify and make associations with on a daily basis with these breast cancer cases. This is one of our biggest challenges as a PA, along with lymph node dissections and complicated cases. These markers we have to identify and talk about their associations, and they're very small. I'm talking like 2 millimeter, 1 to 2 millimeter markers. A little introduction: the Expert 80 by KUBTEC is a self-contained radiographic imaging system that we utilize predominantly breast cases for, but we use this on a daily basis to basically bring about better quality of care for the patients. And it's got a lot of cool tools and image type processes that you can utilize while using it. Really a great system. I'm going to get more into detail about this later on. So where the system excels, there's not much training in utilizing the machine or the system. It's got a large detector for mastectomies, lumpectomies, amputations, all kinds of variety of specimens. It's a stainless steel chamber, and the door is lightweight. The whole system's not this big, bulky, heavy system I've seen in the past with other manufacturers of these systems. It's ergonomically very mobile, has a very mobile design. It's on wheels, mobile. It's got a mobile cart. It's got a monitor and mouse and keyboard apparatus that you can move up and down depending on the height of the Preceptor, whoever's utilizing the system. The images are easily uploaded into a network folder or the LIS. You can also put it in packs. You can there's a lot of variety in what you can do with the images, so that's nice. How it works? Well, here's an example of one of the main specimens we use the system for. It's a lumpectomy case. There's a QR code here. You can scan that, and feel free to watch that video on how we kind of process our lumpectomies. But here we have a lumpectomy specimen that's oriented with sutures, and we ink it, we section it, and we lay it out sequentially, radiograph it, find the marker or markers, and make the associations with an additional picture that we annotate. And that's what's kind of cool with the system as well, is it not only takes a picture of the radiographic image, but takes a picture of the specimen gross photo. And you can actually do everything in once. You can do the annotating and save it, and then you can save the radiograph as well. And you can also these are overlaid, and you can kind of go back and forth with looking at more of the radiographic image or looking at the gross image to find out exactly which slice the marker is in. So it makes guessing and then what number slice it's in a much easier process. So at this point, I've already inked and sliced the lumpectomy specimen up. I'm going to put it into the KUBTEC. Once I've shut the door, I kind of look in there and see if it's centered or not. And we use our own individual personal trays instead of taking out the tray from the KUBTEC. Makes it a little bit more easy and convenient for all of us. So I'm going to come over here. I've already entered all the patient info and the accession number and whatnot. I'm going to hit 2D and start the radiograph process. I love the screen and the keyboard on this unit. We can move it up, down, left, right. It's just really convenient as far as ergonomics goes. And it's a really nice big screen. So we've got a few more seconds to go on this. We'll have an image. And what's nice also about this machine is you can actually get the optical image along with the radiograph, as you see here. And then I use the blending option to kind of go back and forth with the radiograph and the lumpectomy image. Kind of figure out where these markers are at, which is really nice. So I've kind of figured out where those are at. You also zoom in if you need to. And kind of go over the optical image and the radiograph image. And I'm going to export this image. And what we do is we put our images into an LIS system. So what we'll do is I'll export the image, save it to our network folder in my individual folder. And then I'll go back to the bench and pull up the LIS system, which is PowerPath for us, and I'll actually import the images into there. And it's really cool about this is because it takes an optical image, you can do the annotating on this, the actual annotations on the image on this unit, if you have to, or if you need to, if you want to. It's kind of cool that takes both images. I put a little survey, questionnaire out there on the Facebook Certified Pathologist Assistant page, just out of curiosity. What happens to these images that we take on the system? 26% are uploaded right into PACS. You have 5% that upload them into the LIS, which I will explain is probably an even better thing to do out of all of these processes. Or 67% don't upload the radiograph image at all. I just simply find the marker and then continue to process the specimen. I'm going to talk a little bit more about the radiologic examination of surgical specimen, the RAD exam code, next. So with this RAD exam code, you can actually charge, or you can actually get revenue for doing a radiographic image of the mastectomy or lumpectomy case, and then uploading it into the LIS so the pathologist can see it, and then there's an associated charge. And a lot of places don't know you can do this. It's a completely separate charge from what, it's a separate entity and a separate charge from what the surgeon does when they take a radiographic image of the lumpectomy or mastectomy and put it into PACS. So just understand there's two separate images, one that the surgeon provides, one that we provide. It goes into our LIS system for the pathologist to look at, which has an associated charge, and you can certainly do that. And that's what we do. This is a lot of verbiage here, or a lot of wording here, but if you bring this to your pathologist or your hospital lead, lab, director, whatever, about getting yourself a KUBTEC system, bring them this, and this will help justify getting it, and talk about how the charge that is associated with the image that we upload into the LIS system brings about revenue. So, for example, in our case, we make about $33 per image. We do about 35 cases a week, breast cases, sometimes more, sometimes less. But we end up looking at this, and you're looking at about $100,000 worth of revenue over a year, and that almost pays for a KUBTEC system. So it would not hurt to take this, bring it to the lab director, bring it to the head of your pathology group, and say, hey, if you're not already doing this, obviously. There's obviously a lot of collaboration between the surgeon and the pathologist assistant. Often with the requisitions, we get a photocopy of the radiographic image of the lumpectomy. Now, this is great. They send this to us, but the quality is always very poor, and you can't really tell. There's one marker, two marker, any markers. So it's very helpful to be able to take the lumpectomy and radiograph it using the system and be able to identify those markers, because the photocopy image is not the greatest. Pathology and surgeon collaboration continue. So these markers are placed in areas of abnormality, of lesion, And if there's something that needs to come out, if it's pre-malignant or it's malignant, or it's going to be bothersome later on, by putting in these markers where they biopsy these patients, if there is an abnormality, they need to take it out. These markers will show and help them go back and take out the area of abnormality. So it's real important that these markers are obtained, they're verified, and and we're talking about the associations with these markers. It's good patient care. Versatility, a lot of versatility with the KUBTEC system, not only breast pathology, but other things as well. So with breast pathology, we're talking about, identifying the marker, calcifications, the identification and location of these markers. We're talking about the association of tumor or confirmation that we got the right area, and also specimen orientation. So let's go through these. So here's an example of a case where we got a specimen, a mastectomy case. We radiographed it, and the markers were not in the correct places according to the history. So when we radiographed the mastectomy, we figured out that the surgeon must have oriented the mastectomy incorrectly. Often the surgeon will put a big clip in one end or one edge of the specimen and say this is lateral, but on occasion, not very often, but it does happen where they put the lateral clip in the medial aspect or vice versa, and we only find this out after we've radiographed the mastectomy or even the lumpectomy. So here's an example of misorientation by the surgeon. Once again, another QR code show you how we process our mastectomies. So a lot of patients are having chemoadjuvant therapy prior to having mastectomy or even a lumpectomy. And when this happens, when the patients have chemoadjuvant therapy, it can almost melt away, not literally melt away, but it can almost remove or lessen the size of the tumor or tumor bed. And sometimes you can have a breast case where, this person had a sizable tumor and they had the chemoadjuvant therapy, and you go and you're palpating the breast, because that's what we first do. We palpate, we look at the breast tissue grossly, and then usually when there's a lesion, we can cut through this lesion and there'll be a marker there. But that's not always the case, especially with chemoadjuvant therapy cases. When you cut through the area of supposed tumor, but there's no tumor there anymore, there's just fat, it can be incredibly hard in finding these markers. So once again, another great use of the system in finding these markers, not only for verification, but when it's difficult, even more difficult to find them because there's no lesion associated with the marker because of the chemoadjuvant therapy, which is great for the patient. It means that, there's no more tumor, and at least grossly. Here's an example of misorientation. Say you have a lumpectomy and you've received it. It's in it's called a Dubin device, where they take the lumpectomy, the original breast specimen, they put it between a plate and they smash or compress the breast tissue. Sometimes it's just way too much. And when they do that, they knock out a marker, knock out a suture, knock out a clip, whatever, and you can't orient it. So you have to call a surgeon, and sometimes they're able to give you information like, hey, if you radiograph it, the marker is closest to the anterior aspect, which can be helpful in orienting these lumpectomy cases when something's fallen in. Amputation. So we're talking about legs, forefoot amputations, digits. You'd be surprised at how much this helps us on a daily basis with roasting these specimens. They're not always clean cut, where they literally come in and it's one piece and you can look at it and go, okay, this is what this is. Often it's not the case. So let me go into this. So you get a leg amputation, below the knee amputation, you're cutting through the lateral, maybe medial malleolus, and you cut into metal, and you're like, oh, this person's got some kind of hardware. So you're like, oh, I'm gonna have to dissect this whole leg open and find out what's what, how many screws, how many bolts, how many brackets, whatever. Instead, you can put it into the KUBTEC system and identify what's there, and then include that in your dictation, and voila, very efficient, very accurate, less less work, and you can get on to the next specimen. So here's another example of this is a transmetatarsal amputation example, where it can be conically cut, where you have a combination, disarticulated, amputated forefoot with all 5 metatarsal heads, all 4 or 5 metatarsal heads and all the digits and associated phalanges. But sometimes you can have an aggregate of tissue where you have multiple segments of bone or disarticulated bone. And you're like, oh man, how am I going to figure this out? Then you have to get into the op notes and look at the op notes, but instead you can put it into the system, radiograph it, and then you can go over your anatomy and be accurate and be efficient. So here's another example. Here's another example to kind of show you the complexity and kind of the what's what when I receive a specimen as an aggregate. So feel free to look at this. Here's another example where there were no op notes, okay? And so I actually x-rayed it, and then I called the surgeon as well to verify that I was accurate in my anatomy and what was received and that kind of thing. So this is really important. It's also important for teaching purposes, especially with residents, with PA students that don't have this anatomy down yet, or don't think of this as being important. You really got to be accurate with all this stuff. The pathology report is a legal document, and you want to be accurate. So you want to be not only efficient, but make sure everything's correct. Bone biopsy. So we get bone cores for metastatic disease, like say, for example, you get a prostate cancer case, and they think it metastasized to some bone, to your hip or leg or whatever. We get these bone cores, and we have to decal them. We can't put it in a regular decal or rapid decal. We have to put it in a special decal, so we're still able to do the IHC and the molecular stain. So this special decal takes several days of decalcifying, and sometimes you're just not sure if it's ready. So you can put it into the KUBTEC system, x-ray it, and see if there's any calcifications left. And you're like, well, it feels pretty soft, but I want to make sure. And you want it to process well, because in the end, histology is going to get it, and it's still calcified. It's going to be extremely hard to cut, and it may lengthen the process of processing this specimen type. So OBGYN specimens, in particular, placentas and uteri. We'll be talking about Easter coils and fetus preparaceous identification. So Easter coils, these are coils that are inserted into the proximal fallopian tubes through the internal openings of the uterine tubes within the uterus, endometrial canal. And a lot of these were put out in years past, but they stopped using them in 2020 because of the complications and problems that women were having with pain, with perforations. And often we don't get this history with the REC, so you've got to be really careful about, make sure you cut through the cornu on these uteri, and make sure you don't miss these Easter coils. I mean, it can be kind of a liability, legality thing. We want to make sure that we document, just like we document with markers in the breasts. Sometimes you need to document these uteri have the Easter coils in them as well, and we'll radiograph it, put it into the LIS. Now, I only had 2 of these cases in 20 years. This is a fetus preparaceous, and this is basically where you have an intrauterine fetal demise of a twin, which occurs early in the pregnancy, and this twin becomes kind of absorbed into the membranes of the placenta, and so you'll see this thickened area of the placental membranes, and it's kind of circumscribed, and you're like, oh, what is this? And so you'll x-ray it, and you'll find these skeletal structures within that area of the membranes. It's pretty interesting and not found very often. but you want to document this. The GI system. So, surprise, but large and small bowel anastomoses are not always as easy to identify grossly, especially for new, like I said, residents and PA students. We get these from time to time for either an anastomotic leak or a stricture, and you get this bowel. It's really tortuous and all stuck together. You're like, well, I got the margins, but what else is going on? So here's an example of someone who had a Roux-en-Y gastric bypass from a prior surgery. And when I opened up the bowel, it was a little bit difficult in trying to identify these anastomotic lines and where they were located at, and if they were intact, if there's any areas of ulceration or tumor. So by utilizing the KUBTEC system, I was able to put this into the machine, say, hey, here's the mucosal margins, here's the anastomoses. This is where I need to concentrate my pathology or my sections where I take them. So here's another example of the system and how it's utilized. Autopsy. With fetal autopsies with congenital abnormalities of the skeletal system, we often radiograph these little guys, and you can identify the short stature, hypoplastic extremities, and rocker bottom feet, which are associated with certain skeletal hereditary abnormalities. Is important to identify these and figure out which syndrome or whatever hereditary genital abnormality they are placed into. So you use it with fetal autopsy cases. Cardiac pathology. I just started doing this, and I'm sure this has probably been happening for years and years and years, but I never thought of actually doing a radiograph of a heart, but I did in order to find the stents within the coronary arteries, and also to find the areas of calcification. Do I need to decal all the coronary arteries? Here's an example of an autopsy case where I dissected off all the coronary arteries, I decaled them, but also radiographed it, and you can see there's a stent here, there's all these calcifications. So it's really helpful and I'll put this in the autopsy, into the LIS system as well. So it really helps out with the degree of atherosclerosis and stent pacemaker identification, which I just kind of briefly went over. So here's here's a more up close, bigger picture of the coronary arteries. I dissected off the heart, and then decaled, and then sectioned and kind of looked at the different areas of stenosis. But it really helped in the areas of stent and where I knew I was going to be cutting through stent material, and also where I was able to identify where those stents were and what coronary arteries or tributaries of the coronaries that they were at, which is very helpful in the gross. So once again, accuracy and efficiency, right? Here's the now I've never seen one of these before, but this is actually a pacemaker within the myocardium of the heart. I've never seen one before, and I just happened to x-ray this heart and say, hey, look at this, and I was able to identify that as well. I didn't expect to have to be there. Here's a complex cardiology case where someone had ECMO, and once again, I was able to radiograph the heart and also help with showing where everything was kind of at as far as the stents and some of the tubing and atrial clips, and where the memory bypass was placed. I mean, it was just very helpful in figuring out where everything was at with anatomy wise. So that's great with these complex cardiology cases. Quality and safety. So many years ago, we would take our breast specimens and we'd walk them down to radiology under a chuck. Of course, these specimens were, saturated with formalin. There was patient information. We had to bring a sticker with us with the patient information on it. While it's all covered up, you got to think about safety, as far as the fumes. There's patients in the hallways walking around with these, watching us bring these specimens down the hall. There's been times where you could possibly drop the specimen. There's a patient, there's a, HIPAA. You got to be really careful with when you transport specimens from one place to another place. You just can't have the patient information just out in the open. Anyways, but the formalin fumes are a big thing, and people complaining about the formalin fumes. So, because long story short, if you have one of these KUBTEC systems in your grossing area, within 5-10 feet of you, you don't have to walk down the hall to radiology, and I think that's important. Time and money saving. So, if you're more accurate in where you're taking your sections, right, you're going to be spending less time. Okay, so you're going to have more time to spend on all the specimens for that day. If you're being more accurate with where the markers are at, because you're not just guessing, you're going to be using less blocks than you would use. You're talking about less recuts, because if you sample the wrong area and the pathologist is like, well, I'll just do some recuts and see if I get to that area of tumor or area of the marker, you're also talking about more time, more money. So in the end, with the KUBTEC system, you can really save all these different parameters that cause more time and more money. And depending on what cassette system you're using, some cassettes are more expensive than others, that type of thing. Okay, and you're also talking about less work for the PA and more time on getting all the work done. So here in a second, I'll show you kind of an equation that you can kind of use to kind of see where your cost savings will happen if you get one of these systems. So if you take the pathology assistant time, average salary is $110,000 a year. Talking about $53 an hour. 30 minutes saved on each case times 35 cases per week, 18 hours of free time for the PA to perform additional tasks, or 45% of the PA's weekly pay is wasted, or $49,000 annually. This is the KUBTEC Pathology Imaging Savings Calculator, where you put in the numbers and see for yourself how much money you'd be saving, whether it's block savings or recut savings or staff savings. You can utilize this calculator for your own hospital and see what kind of cost savings you would get. As you can see here, the cost savings for us are $336,000 per year for recuts, $151,000, and the staff savings. This calculator can be really useful if you're at a point where you're not able to get all the work done on a daily basis. The lab leaders are going to be thinking about hiring another pathologist assistant or hiring a grossing tech to come do all the stuff that you do in order for you to get the breast cases done. This calculator can show them they don't need to do that. They can get a KUBTEC, get the work done, and probably still save money too. If you need access to this calculator, please feel free to reach out to KUBTEC, and I'm sure they'll be happy to provide you with a copy to calculate your potential gross room savings. Now, funding. So here's another QR code for the capital request form. You're welcome. Feel free to kind of scan this and download it and use it if you want to. So for us, anyways, financially, our systems, we have more than one. We have 3 of these KUBTEC Expert 80s. They were all financially supported by the hospital. So we submitted a minor capital request, and what we had to do, though, is justify the purchase. Why do we need the system? And after the end of this presentation, you'll have all the information you need to justify it. And feel free to utilize any of the verbiage or anything I gave you, so you can hopefully get yourself a system and make your life easier, more accurate, more efficient, right? So the final cut. We absolutely love the system. The pathologists, the PAs, the residents, the PA students, we all love the KUBTEC system. Makes our lives easier. I can't imagine not having it, and I'm surprised that I don't know how pathology groups. I guess they can get the work done, but surely not in the same efficiency and probably not in the same accuracy. I mean, if you want to, in this field that we're in, we need to be accurate as possible and as efficient as possible. It's all for patient care, and this system is very easy to utilize. And I think if you can get it. You can obviously get it if you bring the right information to your pathology group or to the laboratory director with the cost savings and how it'll basically pay for itself by utilizing the RAD exam code for breast cases and putting that into your LIS system. So why KUBTEC? Here's some feedback from some pathologist assistants. Here, I've used both and absolutely prefer the KUBTEC. KUBTEC customer service with Hologic. Vaxtron was less than ideal. We have a KUBTEC and it has this amazing blending option that will take the picture of the specimen and overlay the iridograph to make clip location even easier to identify. And that's that perk thing that I really like about the KUBTEC. And the customer service is great, and it's not a big bulky machine. It's light, easy to move. The door isn't super heavy. What main feature I like is taking the not only the radiograph and the photograph at the same time, and then being able to annotate it all in one motion. I mean, that's just fantastic if you guys do that kind of service. And I think it's a great REST service. So that's all I have, and I'll be here for questions. And feel free to email me if you need that equation or that fill-in area to kind of find out what kind of savings you can get to bring this to your group. Thank you so much for watching, and thank you KUBTEC for allowing me to do this for everybody. Thank you.
So Jay, thank you very much. That really was a very informative presentation.
My pleasure.
I greatly appreciate you sharing your experience and your expertise with us. We do have some questions that have come in. And to the audience, feel free to keep sending them in. So the first one we have here is, can the system see even the smallest of biopsy clips?
Yes.
Okay.
Even the smallest ones. I mean, on that one mastectomy photo with all the, copied and pasted clips, that's just a handful of many. And I feel like these images are better than MRI images. I mean, they're even better. And there is a handful of other ones that are smaller than the ones that are on that mastectomy, and you can find any of them. And you also have the ability to magnify too. With the KUBTEC, you can magnify in different strengths and find them. So I've had no difficulty in finding any clip or any marker.
Okay. So next one here, what is the learning curve like for someone with little to no X-ray experience?
It's very simple, actually. I think it was like when they came to, the KUBTEC reps came out to show us how it worked. It was like maybe 10 minutes, and that was it. The learning curve is very, very easy.
Great. Another one here. How much longer is it to take a blended image?
Well, I mean, so once you take the image of the mastectomy, lumpectomy, I mean, you're automatically put into that field where you can blend. I mean, it's not there's no extra process or time to put it in the blending mode. It's part of every process. Yeah.
Yep. And there's a related question. How often do you use the image blender?
I use it with every case.
Every case. Okay.
Yep.
Great. There's another one here, which I think I'll take this one. So, is the Expert 80 the only product that KUBTEC has, or are there other options? So it's a great question. I think the short answer is no. That there are other systems. There's three other systems, or there's three systems in total for pathology. Jay showed us the Expert 80. There's a bigger brother of the Expert 80 called Expert 80L, which has a larger detector at 17 by 17 inch. And then we have another product called the Mozart Supra which has the same imaging area as the Expert 80, but it also offers 3D imaging based on tomosynthesis technology. And they've all got the image blender and all the other workflow features that you've seen. Actually, that reminds me, I should have mentioned this earlier, but if you want to see these products, you can go to our website or you can email us. If I could just ask someone on the KUBTEC team to put that link into the chat for everyone, the link to the website and also the email address, which is kubtec@kubtec.com. Okay, so just check if there's any more questions. I think we have at least one more here. Yeah, there's another question here about, so how did you originally get your team to commit to buy the system?
Well, for us, we had another vendor. I won't necessarily mention another vendor, but the experience we had with the other vendor was not ideal, and we didn't like the whole process of that, and also the some of the suggestions they made it even more expensive, you know, at that point. And so when this other when KUBTEC came in, it was just something that looked better for us. It was, you know, mobile and just a much easier machine to use, and customer service was great. And so that's why we went down that route, and we're happy. We've got 3 of these at 3 different locations, and we use them all the time. It's very easy. And also, as far as the LIS system goes, our IT department just got right in and set us up with the network folders, and that was a very easy transition as well. So
okay. Great. So another one here. What program do you use to annotate your photos?
oh, go ahead.
Oh, no, you go.
So, I mean, there's a variety. This kind of depends on what you like. You can throw it into Paint. You can pull it on PowerPoint. What we often do is we bring the radiograph to we put it in our network folder, then we download it to LIS, and then at the gross bench, we have spot imaging. So sometimes what we'll do is we'll take a picture with the spot imager and then annotate it, and then put that in our network folder as well. But there's been a couple sites where we didn't have a camera at that point, and so we had to, and we were actually very grateful that we had the ability to not only get the gross photo but the radiograph at the same time. We would take that and do it in Paint, save it, and throw it in our network folder and then our LIS. So it was really cool to be able to do that, because a lot of machines I don't know if they necessarily, you know, take both images like that. So
Great. I'm just checking for any more questions here. I think that actually covers all of them.
okay.
Come through so far. So I think, yeah, we can begin to wrap up there. I'll just say thanks again, Jay, for your time.
You're welcome.
We appreciate it. And thank you also to everyone who joined today or who's going to watch this at a later time across the globe. We appreciate you being here. We certainly hope you found it insightful. And I think it's been mentioned before, but this webinar will be made available to all those who registered. You'll be sent an email with how to access it, so you can view it at a later time as well. So
thank you everybody for watching. I appreciate it too. And thank you, Richard.
Yeah, it's our pleasure. And thank you so much again, Jay.
Sure, you're welcome.
Thank you.